Good afternoon, and welcome to this session of the AgrAbility webinar series. My name is Paul Jones, and I am the manager of the National AgrAbility Project. And today's topic is on osteoarthritis and obesity. A few quick webinar instructions before we get started with the presentation today. Today's session is using a phone connection for our audio. So hopefully you are hearing me. If somebody could give me an affirmative on that, I would appreciate it. The phone lines for the participants are currently muted. So a couple of options for asking questions during the presentation. The first is that you can simply type questions into the chat window, and we will gather those for the question and answer session at the end of the presentation. Also, because we are using the phone connection, we will be opening up the phone lines at the end for questions. So if you would prefer to ask your question verbally, simply wait till the end and we will open the phone lines. We will be asking 4 quick poll questions at the end also. So if you could please stick around and give us your feedback. Also, we are recording this session, and it will be archived along with the PowerPoint presentation on our website. That site is listed on your screen at this point. If you don't happen to remember that, just go to the agrability.org website and look for online training, and you should be able to find it from that link. If you have any problems in terms of technical issues during the webinar, please go ahead and type those into the chat window. If you cannot use the chat window, then please just email us at agrability@agrability.org. Cliff, it looks like our captions are not running right now. If you could please check on that, I'd appreciate that. I thought I'd connected it, but I may have entered the wrong number there, so thank you. A few issues that we know are sometimes problematic with our webinars. Chrome is somewhat contentious with Adobe Connect, so if you are using Chrome and are having some difficulties, you might try a different browser. If you're getting some echo, you might check to make sure you're not logged into the session twice. If we happen to get disconnected with our presenter, please just hang on, and we will attempt to reconnect as soon as possible. And if you are disconnected as a participant, please just log in again. For those of you that are not familiar with AgrAbility, we are sponsored by the U.S. Department of Agriculture, and our focus is on working with anybody involved in agriculture that has some type of physical impairment or disability. Every AgrAbility project is a partnership between a land-grant university and a disability services organization. Currently, your screen is not quite correct because we have 20 projects covering 22 states instead of 23 covering 25 states. And we have one National AgrAbility project that is based here at Purdue University through the Breaking New Ground Resource Center. Our partners on the National AgrAbility project include Goodwill of the Finger Lakes, the Arthritis Foundation Heartland Region, the University of Illinois at Urbana-Champaign, and Colorado State University. If you'd like more information or more resources related to arthritis or other topics germane to AgrAbility, please visit us at agrability.org. Just a brief background on our presenter today, Dr. Stephen Messier. He is joining us from Wake Forest University, and you can see from your screen that he has extensive experience not only at Wake Forest but in the field of osteoarthritis, has many publications in this area, and has been working extensively in the area of the connection between exercise and weight and osteoarthritis. I'll describe in much greater detail. So at this point, I'm going to bring up his presentation. And I will go ahead and eliminate my camera for now and mute my microphone. If Dr. Messier would like to unmute his microphone, then he can go ahead and begin the presentation, and we will join you afterwards for the question and answer period.
Okay, Paul, thank you very much, and it's a pleasure being here. Kind of a unique situation for me. I've done this once or twice before, so, but anyway, we're going to talk about the effects of exercise and diet and osteoarthritis. And for those of you who are not familiar with Wake Forest University, we're in Winston-Salem, North Carolina. This is a picture of what it looks like right about now. It's a really nice time of the year in North Carolina. It's beautiful in the springtime, late springtime. And that's the chapel, where you might recognize or have heard that two of the presidential debates were actually there. So it's very nice. We actually, for those of you up north, we actually do get some snow. This is about the extent of it. As you can see, it's not very thick there, but it does make it really pretty. Maybe once every 2 or 3 years, and then it's gone the next day. And this is just of the university. So if you ever get down to this area, you need to stop in. It's a really pretty campus. This is our clinical research center. It's just off of our campus next to our athletic facilities, and it's a air-conditioned building. It's got 13 laps to the mile going around, and then you can see where people are weight training in the middle. There's actually even some bikes on days that are arthritic people, if their knees hurt too much to walk, then we can put them on bikes as well. There are rooms off to the side for counseling on nutrition and giving small talks like I'm giving right now. We can facility. The really nice thing about it, it's all on one level, so there's lots of parking, so people can come in. They don't have to go up or down stairs. So this is where all of our clinical trials are done. And it's built specifically for the clinical trials. There's nothing else that goes on here except for our research studies. This is our OA research team that is international in scope. People from Austria, Australia, Boston University, University of North Carolina, Chapel Hill, and of course at Wake Forest University. And I need to acknowledge our funding source, which is the National Institute of Arthritis and Musculoskeletal Skin Diseases, which is part of the National Institutes of Health. So what I'm going to talk about today is knee osteoarthritis. And the prevalence of knee osteoarthritis worldwide is over 250 million, almost the population of the United States. So it's 3.6% of the world population, and as you can see, women are affected almost twice as often as men. So how do we treat knee osteoarthritis? Well, the short answer to that is not very well. The average time spent living with symptomatic knee osteoarthritis is over 26 years. The first 3 years usually is a combination of nonsteroidal anti-inflammatory drugs and braces. And then there's a period of about 2 to 3 years where there's various types of injections, steroid injections, hyaluronic acid. And then after that, there's this remarkable period of about 13 years where there's no real definite treatment plan, just using analgesics as necessary. And unfortunately, what is happening during this time is at least half those people are just biding their time, getting ready for a knee replacement. And in fact, over the last 20 years, there's been a 162% rise in knee replacement surgeries at a cost of about $5 billion annually. And obesity is a major risk factor for knee osteoarthritis. In fact, looking at this figure, you can see that people who are severely obese, that is BMIs over 40, are 17 times more likely to have knee osteoarthritis than normal weight individuals. So if that's not enough to get your attention, how about premature death? People with BMIs as over 30 have an increased risk of death in people that are ages 25 to 59. So, how can we reduce weight and relieve pain? Well, Americans are always looking for a pill to be the answer to everything. And in response to the latest weight loss pill that was cleared by the FDA, Obesity Society President Patrick O'Neill said he's encouraged by the drug's approval because it underscores the notion that lifestyle changes alone are not enough to treat obesity. Let me repeat that. That lifestyle changes alone are not enough to treat obesity. In other words, if you're overweight or obese, you need something else other than the discipline to be able to lose the weight. You need to either have a pill or I'll show you another option in a minute. But hopefully by the end of this talk, if you feel this way, hopefully I will convince you otherwise. So another way to lose weight, of course, is through surgery, which has been very successful for people with diabetes. Fortunately, I think that we have not resorted to this surgery for people with arthritis, at least not yet. Many surgeons use arthroscopic surgery to relieve pain and improve function in people with mild to moderate knee osteoarthritis. In this classic article by Mosley, he compared people who went through arthroscopic surgery with a group who did Sham surgery. So what he actually did was in half the group, they actually did not get the surgery, but he actually brought them into the surgical unit. They actually had all the surgeons there. They put them under with anesthesia, and they made little cuts that didn't go into the joint, and stayed in the surgical room and talked just like they were doing the surgery in the chance that they actually could hear a little bit while they were under the anesthesia. And then what they did is they looked at the pain over 2 years after the surgery or after the sham. And as you can see that the surgery and the sham both decreased pain at about the same amount. So in other words, this surgery had no significant effect on pain compared to a sham. So in fact, the results of treatments of chronic non-cancer pain, which includes osteoarthritis, are sobering. The best evidence for pain reduction averages roughly 30% in about half of the treated patients. So there's plenty of room for improvement, 30% in about half the treated patients. So can a non-pharmacologic, non-invasive intervention be part of the solution? And we have spent over 25 years trying to reduce knee pain in older adults with knee osteoarthritis with exercise and weight loss. And what I'm going to talk about today are the results of our recently completed trial called the Intensive Diet and Exercise for Arthritis, or IDEA trial. Our model suggests that we can impact both the biomechanical and inflammatory pathways to knee osteoarthritis with intensive weight loss and exercise. The intensive weight loss and exercise will decrease joint loads and decrease inflammatory cytokine activity, in other words, decrease inflammation. both of these resulting in decreased subchondral tissue damage, less cartilage loss, and less synovitis. And of course, most important to the patient is a decrease in pain and improved mobility. Why do we study the knee? Because osteoarthritis affects the small joints of the hand, it affects your vertebral column. Why do we study the knee? It's because the knee is really crucial in mobility. And when you lose your mobility, things go downhill very rapidly for an older adult. So the IDEA intervention included 3 groups. The control group was actually an exercise group, and then we had a diet-only group and a diet plus exercise group. All 3 interventions were 18 months in duration. The exercise intervention consisted of 2 15-minute walking periods that were separated by a 20-minute weight training period. And this was 3 times a week for about an hour each time for 18 months. The nutrition interventions began with an initial energy intake deficit of about 800 to 1,000 calories per day, and up to 2 meal replacements per day of about 300 calories each. The third meal was between 500 and 750 calories and low in fat. The weight loss goal was the minimum weight loss goal was at least a 10% loss in body weight over the 18 months. The intervention groups met weekly for the first 6 months, and then bi-weekly for months 7 through 18. Of the 454 people that were randomized to one of the 3 groups, 399, or 88%, completed the study. So we were very pleased with the high completion rate. Adherence to the exercise for the first 6 months for the exercise-only group was 66%, and overall for the 18 months was 54%. For the diet plus exercise group for the first 6 months was 70%, and for the 18 months combined, it was 58%. So adherence was the number of sessions attended divided by the number of sessions that were planned. Okay. Adherence to the diet intervention for the diet-only group was 61% over the 18 months, and for the diet plus exercise group was 63%. Adverse events for the 454 participants over 18 months, there were only 3 non-serious adverse events, or less than 1%. There was 1 muscle strain and 2 trips and falls. There were no serious adverse events related to the study, and fortunately for everyone involved, there were no deaths. So this is the weight change over the 18 months for each of the groups. You can see that on the right in the table, you can see that the diet-only group lost on average 9.5% of their body weight. Remember, the goal was 10% on average. And the diet plus exercise group lost 11.4% of their body weight. And the exercise-only group lost 2% of their body weight over the 18 months. So this figure shows a month-by-month weight loss for the diet plus exercise and diet-only groups. You can see that both the diet plus exercise and diet-only groups lost most of their weight over the first 9 months, but then continued to lose weight all the way to 18 months with no regression towards baseline weight values at all. So they did not, most weight loss studies, you lose weight, and then they tend to regress back to baseline, and we had none of that over the course of 18 months. You can see here that the addition of exercise accounted for about 2% more in weight loss compared to diet by itself. So really in this population, exercise is really a weight maintenance intervention. It's really not a weight loss intervention. In order to lose substantial amounts of weight, you just have to eat fewer calories. This is a scattergram of the weight loss for the diet plus exercise group. And you can see that about 50% of the participants reached their weight loss goal of 50% or more, of 10% or more of weight loss in the dark area above. And then about 25% were between 5 and 10% of weight loss. And then about 25% were between 0 and 5. And almost identical for the diet-only group. Half the group reached their weight loss goal of 10% of weight loss or more, 25% between 5 and 10, and then 25% between 0 and 5. This is looking at the change in lean and fat mass, and you can see for the diet-only group, let's do the diet and exercise group first. For the diet and exercise group, of the 10.6 kilogram weight loss, 61% of that was fat. And for the diet-only group, of the 8.9 kilogram weight loss, about 54% of that loss was fat. So, with weight loss, even with exercise in this getting a message. I know the beeping is outside. Sorry. Even with exercise in this population, as in most populations, all the weight loss is not fat. There's a good amount of muscle mass that's lost as well, and that's not a good thing for anybody, especially for older adults. So that's something that in the future we're going to have to address one way or another. So one of the main outcomes was pain. Of course, that's what participants care most about, is pain, because pain can really affect their daily life. And what we saw is that after the first 6 months, all three groups lost about the same amount, decreased their pain about the same amount. It wasn't until 18 months that the diet plus exercise group really distinguished itself from the other two groups, losing or reducing their pain by over 50%. Right? The other two groups did well, 25% decrease in pain for the diet group and a 28% decrease in pain for the exercise-only group. But it's really the diet plus exercise group here that was the winner. The question is, why? What happened? If we had only done this study for 6 months, then the results would have been no difference between the groups. All three groups did well. But by 18 months, there was something about the combination of exercise with diet that continued to decrease pain over time. And we're not quite sure what that is. There might be a psychophysiologic effect of exercise over time. That, when combined with weight loss, results in this dramatic decrease in pain. But we're not quite sure about what that mechanism is. But very interesting that it took 18 months. Similar results for function. About the same decrease, improvement in function over 6 months, but by 18 months, the diet plus exercise group had improved function by 47%, which was significantly better than the diet-only group and the exercise-only group. Walking speed is important. As we get older, we tend to lose walking speed. And you can see here that all three groups actually increased their walking speed to the point where by 18 months, the exercise-only group and the diet plus exercise group had walking speeds that were equivalent to healthy 40-year-olds. And the average age of these folks was just under 70. And they had knee pain, of course. So it went really well. They all did well. The diet plus exercise group walked significantly faster than the other two groups. But all three did well. And this is 6-minute walk distance. How far can you walk in 6 minutes? And the results were similar to that of walking speed, again, with the diet plus exercise and the exercise-only groups doing better than. We also do something called musculoskeletal modeling so that we can examine the forces that are exerted on the knee joint. And we took blood, so we collected the blood and we did blood assays to look at inflammation. And looking at the compressive load on the knee joint, you can see that both diet groups, the diet-only group and the diet plus exercise group, significantly decreased the load on the knee compared to the exercise-only group. In fact, the diet-only group decreased the load on the knee over 300 newtons. That's about 67 pounds. So, in other words, after 18 months, every step that someone took in the diet group, they had decreased the load on their knee by 67 pounds. So imagine putting 67 pounds of weight on your knee extra. That's what that would be like, and they took that off. And IL-6, interleukin-6, was a measure of inflammation, and both diet groups had significantly less inflammation after the 18 months, 16% decrease in the diet-only group, and a 13% decrease in the diet plus exercise group compared to a 3% increase in the exercise-only group. So what we did is, what this slide shows, we took all the variables that we examined, and we added them all up and put them on the same scale. And so what we have here are z-scores, or standard z-scores. And so anything above 0 means an improvement from baseline. And what you can see here is while all three groups improved overall for all the variables combined, the diet and exercise group was the clear winner, having about twice the effect that exercise only and diet only has. So then what we did is we took all the people, irrespective of the group that they were in, and we looked at the dose response of weight change with pain and function, independent of the group that they were in. So what we have here is three groups. On the left-hand side of that table, we have the high weight loss group, that is those people who lost at least 10% of their body weight. Then we have the medium weight loss group, which is between 5 and 10, and then we have the low weight loss group. And what you can see here is that the high weight loss group had a significant decrease in pain compared to those in the medium weight loss or the low weight loss. So lower numbers in pain are better numbers. So the high weight loss group had significantly reduced pain compared to the low weight loss group and the medium weight loss group. And the same thing happened with function, that the high weight loss group had significantly better function, irrespective of group that they were in, right? Assignment, group assignment, compared to the medium weight loss group and the low weight loss group. Now, the National Institutes of Health recommend at least a 10% body weight loss as an initial loss for people trying to lose weight, and our results really confirm that you really get more bang for your buck with at least a 10% weight loss. So really that 10% is really the goal that you should be looking for. All right, you really get a significantly better improvement in pain and function and mobility with at least a 10% weight loss. How much is that? The average person in our study was just over 200 pounds, so you're talking about a 20 to 25%, or 20 to 25 pound weight loss over the course of the 18 months. And here's looking at it in graphic form. This is the knee compressive loads that we talked about, and you can see the 10% weight loss group had significantly decreased compressive loads, irrespective of the group that they were in compared to the other two, the less than 5 and between 5 and 10. And the same for inflammation, that the 10% weight loss was significantly less inflammation compared to 5 to 10% or less than 5. So in conclusion then, on average, our diet and exercise intervention was twice as effective at relieving pain as previous long-term OA trials, and twice as effective as non-pharmacologic trials of chronic non-cancer pain generally. Intensive weight loss significantly impacts both the biomechanical, which is the load, and the inflammatory OA disease pathways by reducing the knee compressive loads and inflammation. So the mechanistic changes then and the clinical improvements, the intensive weight loss and exercise results in reduced abnormal stress, which is decreased joint load, reduced abnormal physiology, which is lower inflammation, resulting in less pain and less disability. So in summary then, there was a significant dose response to weight loss. 10% weight loss resulted in superior results relative to 5 to 10% and less than 5% weight loss. So can physicians help? Well, only 42% of older obese adults who visit doctors are advised to lose weight. What's worse, only 0.7 minutes, 42 seconds, are spent discussing diet or exercise. So what is the future of weight loss and exercise interventions? Well, one thing we really realized after this, and the participants really told us, is that why didn't my doctor just tell me I needed help? And that's exactly right. They need attention. While it sounds easy to do, just lose weight, it's not that easy. And so people really need help and regular attention to succeed. The question we have now, and we're exploring, is how can we take what we learn in this trial and put it into the community? And so that's our next step. Now I'll leave you with this. My wife said, "What you doing today?" I said, "Nothing." She said, "You did that yesterday?" And I said, "I wasn't finished." So thank you very much.
Thanks very much, Dr. Messier, for that helpful information. Definitely eye-opening in terms of some of the effects that we expect to see that we don't see, and some of the ones that we see that we didn't realize were so impactful. So I think this is really helpful information for our AgrAbility staff to know that they can actually affect people's health by just encouraging them to make these kinds of lifestyle changes. So at this point, I'm going to give our 4 quick poll questions. And if you have questions you would like to ask through the chat window, please go ahead and enter those in. And in just a couple minutes when we're done with the poll, I will open up the phone lines if you would like to ask Dr. Messier any. Our first poll question just asks about your professional affiliation. If you could please let us know what group you belong to. Appreciate that.
I'm a professor at Wake Forest University in Winston-Salem, North Carolina. My undergraduate degree is in civil engineering. My PhD is in biomechanics. And so I do a lot on gait analysis and on large clinical trials similar to the one that I just talked about. And I've been at Wake Forest for 33 years.
Thank you. Okay, for our audience participants, if you would go ahead and respond to this next poll question on your screen. It asks, it says, the information presented during the session today was valuable and met my expectations. If you could please click on the button that most accurately represents your views on that.
Paul, do you want me to try to answer that question about the community?
Hang on just a second, and when we'll just do these other couple poll questions, and then we'll get to those in just a second. Okay. Thank you for responses on that. poll, and there are your responses, as you can see there. Okay, our third poll question for our audience members. If you could respond. Asked about the technology that was used today, and again, we apologize for the absence of our captioning. Apparently there was a glitch on the captioner's end. We did call them, and they indicated that there was some kind of issue with their servers, so we were not able to get those captions. We are recording the session, so that will be available, and the PowerPoint should be available also. Second to respond to that.
You want me to, what's the question?
That was just for the audience members. I'm just
okay.
putting the polls there.
Okay.
And one last poll question for our audience members. Based on today's session, I would attend another session in this series. If you go ahead and respond to that. And thank you for your responses on that question. Okay, Cliff, it looks like we do have a couple of questions in the chat pod. So if you could go ahead and enter those for Dr. Messier, then we will take those questions and then open up the phone line after it's done. So Dr. Messier, if you'd like to go ahead and respond to the question on the screen.
Sure. Amber asks, how durable are total knee replacements for agricultural woodworkers that are frequently in stressful, repetitive, and aggressive work situations? Well, the average knee replacement lasts about 15 years or so, give or take a little bit. So you really want to only, if you have to have a knee replacement, you only really want to have one. So the problem right now is that with the obesity epidemic, that people are getting osteoarthritis at earlier ages, in their 40s and low 50s, and the knee replacement is very effective. I mean, it really, when you have severe pain, and the knee replacement is a very effective option. The problem is there's risk to that, and then if you have to have a second knee replacement on that same knee, then the risks get greater the more surgeries that you have. So, I attended a meeting, orthopedic surgeons in New York City a couple of years ago, and they said in 20 years there's not going to be enough orthopedic surgeons to do all the hip and knee replacements. So we actually have orthopedic surgeons now calling me and saying, Steve, you got to do something about this. I can't do all these surgeries. So when you have orthopedic surgeons saying that they can't do all the surgeries, you know there's something really going on that we really need to take care of. So our goal is to try to either prevent having the surgeries at all, or at least delay that surgery to later on in life. So if you have to have it, you only have to have one. And read from the main window. Sure, Cliff, where you're talking about. I see one over here on chat. Is that the one? Oh, in the middle. There's nothing in the window in the middle. Nothing in the window in the middle. I'll answer the one from Sandy. It asks, how likely are farmers, ranchers to follow an exercise program? You know, that is a great question, Sandy. I mean, it's not just farmers and ranchers; it's anyone. You know, and how And so what we're doing now, I mean, when you give people attention like we give them, then they do a very good job. They do a very good job. But if you go into your doctor's office and your physician says in 42 seconds, you ought to exercise and lose weight, and that's the end of that, then most likely they are not going to do it. So, and I talk to physician groups all the time, and I tell them about that 42 seconds, and just for them to save their breath because it's not doing the participant any good at all. And really, the physicians really want to help. That's what they were trained to do. They really want to help. They just don't know how to make it work in the real world. And so I tell them that's our fault. We're the researchers. We're the ones that have to find the results and make it work for them. And so what we're doing now is we're trying to take what we learn in the IDEA trial and develop a program that can be used in the communities. And certainly one of those communities would be the agriculture community, for sure, for sure. And so we're in the process of doing that. And one of the big things is that we have to find methods of communication with people that are time efficient and cost efficient, but that we can still communicate with people on a regular basis, because they do need that attention. They really do. And so that's where we are right now, but that's a great question, Sandy. Next question is, so the exercise mainly was walking. Yes, it was. It was mainly walking. Why did we include walking and not some of the others, like yoga and swimming? It's because walking is such a basic part of being able to be mobile. And so, and you could do that across all socioeconomic groups. So we thought walking should be the base, because you can pretty much do walking anywhere. And that's why we used walking. Do daily chores count? It depends. There are some people who suggest that accumulating minutes of exercise by parking your car further from the mall or going out and cutting the grass, all those kinds of things, or what farmers do, is exercise, and it certainly is exercise. But whether that is as good as concentrated 40 or 50 minutes of exercise as we did here, I think that is still open for debate on which one is better, if one is better than the other. I tend to like to do the 1 hour, get it done for the day kind of thing. But certainly there are people with the other opinion, the alternate opinion, that is just accumulating minutes of exercise during the day is just as good as doing, say, the 1 hour of concentrated exercise. Next question is there a plan to develop exercise programs to take to the community? Not only just exercise, but exercise plus the weight loss, because you can see that the weight loss is really the part that really decreases joint loads and decreases inflammation. So you really have to have the weight loss as well. And these are for people who are overweight or obese. There are people who have osteoarthritis who are not overweight or obese, and of course then we really wouldn't want them to lose that much weight, and then the exercise would be the major intervention for them without. What about cartilage that is gone? Yeah. You can have different degrees of cartilage loss, from mild to moderate to what we would consider bone on bone. And bone on bone, it's interesting. If you look at an X-ray and the correlation between the severity of the X-ray, the severity of the osteoarthritis on the X-ray, and pain is only about 0.3. So that means someone can have a really bad-looking knee on the X-ray and have almost no pain, or the other way around, can have pretty good-looking knee and have a lot of pain. So the X-ray is not real specific, and we're looking more now towards MRIs and CT scans, but of course those are more expensive right now. But next question is, was there a particular diet plan that was used in the study? No, we just did a normal diet, all right, a normal diet, just eating fewer calories. So really, it was caloric restriction. It was staying on a normal diet with no more than 30% of the calories from fat and just eating fewer calories. So it wasn't, it was a simple equation. You know, calories in, calories out. So you had to eat fewer calories. And we did that, but in a very gradual way. We would not want more than 0.5% or 1% weight loss over a course of every 1 to 2 weeks. So, and the meal replacements helped. We had them, they could do up to 2 meal replacements per day for the first 6 months, and then we gradually weaned them off that. And we only used them after that in case they got to a point. A lot of people got to about 6 to 7% weight loss, and they couldn't, and they hit a plateau, and they couldn't lose any more weight. And so then we'd come back with the meal replacements for a couple of weeks, kind of as a booster, kind of to get them going again, to get them up to that 10% weight loss. And the 10% weight loss is important, as you saw, with the significant decrease in pain. And a lot of people get to 7 or 8% weight loss, and they felt pretty good about themselves. They go, wow, I look good. You know, they're talking about a 70-year-old woman who had never exercised or anything her whole life. She's looking good, and she felt pretty satisfied. And so we try to convince them to go up to 10, but in the end, it's what the patient wants that counts. So if they felt really good at 7 or 8% weight loss and didn't want to go, then that was all the power to them. And we did what they wanted at that point. Last question. It says, how likely are farmers and ranchers to follow an exercise program? I don't think they're any less likely to follow one than anyone else. Again, they require some help, some attention. Says we've got another one coming. You said that there would need to be fewer calories to have substantial weight loss. How much? Yeah. Well, it depends on the person. It was very individualized. For women, per day, the minimum amount of calories was 1,100, and for men was 1,200, but that depended on the person. So it was very much individualized, but there was a minimum number of calories, and it was 1,100 for women and 1,200 for men. So this was not a very low calorie weight loss program of 600-700 calories a day. We did not do that. It was a very gradual thing, and as you could see from the figures that I showed, most of the weight loss took place at about 9 months. And then there was still a gradual weight loss from 9 months to 18 months. So there was nothing extreme about this whatsoever.
Looks like we've got one more question in the chat pod, and then we'll open up the phone lines in case somebody else has a question they'd like to ask verbally.
Did you have individuals who had too much pain to do the walking? Another great question. We took people with mild to moderate knee osteoarthritis, so the people you were talking about that had bone-on-bone were not part of this intervention. So, and the reason for that, there is a point where the knees are so far gone that probably the only thing that's going to help at that point is a knee replacement. So what we're trying to do is to prevent people from getting to that point. So people who had bone-on-bone, no cartilage at all, really high amounts of pain were not part of the study.
Okay, if you would like to ask a question verbally, the phone lines are now open. So we've got a couple more minutes left in our hour. Questions from the audience?
what about the strength training? Put in 15 minutes of that as well as 20 minutes of weight training, segments for walking.
Right. We had done a previous study called the Fitness, Arthritis, and Senior Study, or FAST, and we looked at weight training compared to walking compared to a control group. So those groups only did the weight training or only did the walking or did a control. And what we found was, what we had is the people in the middle were doing the weight training, the people walking were going around. And we found that the people doing the weight training were looking at the walking people and going, boy, we'd like to do some of that. And the people walking would look at the weight training people and go, God, we'd like to do some of that too. So in the next study, we thought, why don't we combine the two? And especially in the beginning with people with knee pain, walking for 40 minutes at a time without stopping is difficult. And you have to gradually get into that. So we thought, well, why don't we do something with that time when they stop, because it hurts. So we put the weight training in between the two walking periods, and it works really, really well. The weight training in this study was mild to moderate weight training, mostly at the lower extremity, but we did some upper extremity too. And so the exercise was really mild to moderate. It was not intense exercise at all. The idea mostly was focused on continuing to participate. Now, the study we have going on now, which is called the START study, which is high-intensity strength training. So we have people doing very high-intensity strength training who have knee osteoarthritis. And everyone said, well, you can't do that because their knees hurt too much. And we're having very good success so far, but we're a long ways away from the end of that study. So the short answer to your question was it was mild to moderate exercise combined with an intensive weight loss.
Any other questions from the audience? Well, you certainly had some good ones, and we appreciate your participation as audience members. And thank you again for Dr. Messier's excellent presentation and answering the questions here at the end. If there are no other questions, then I guess we'll wrap things up. And again, thank you to everyone who's taken part in this. Messier.
Thank you very much, Paul.